Next speaker is Andrew Goodwin. Andrew works with me at James Cook, and he'll be presenting our experience with the Manubrium-limited sternotomy incision.
Thank you very much. I'd like to thank the Society for inviting me to speak today. I suspect most of you, Enoch asked me to give this talk, and actually he's done most of the work for this MAVRIC trial, so he should probably be giving the talk himself, but seeing as he's chairing it, somebody else had to give the talk, but hopefully I'll give a good representation of a lot of the work that we've been doing in Middlesbrough. I think some of the answers and some of the discussion we've been already having, which incision we've been using, the learning curve and things like that. The learning curve in particular, I'm not going to present the data now, but as Enoch has just said, we've tried to overcome that by developing the program long before we start using it for a trial. So what I was going to go through today is why are we doing Mini AVR, I think, and then move on to why we've particularly chosen to use the Manubrium-limited approach. How does it differ from other surgical approaches? What are the results of the cases we've done in Middlesbrough? And then go on to just outline the MAVRIC trial, which hasn't actually started recruiting, and will start recruiting in the next week or two. It's interesting hearing people hear about all their difficulties of recruitment, so hopefully we don't experience the same difficulties in Middlesbrough, but as everybody says that after the event it's much harder than you thought beforehand. I think 5 years ago we wouldn't have even been debating this. Everybody coming with severe aortic stenosis would have just had the first operation on the list. Conventional AVR was the only operation. It's the gold standard for aortic stenosis and there's no other options. But we've been hearing that 40% of the cases having AVR in Germany are now having it done with a transfemoral TAVI approach. But there's now a host of, it's a spectrum of choice between a full sternotomy and what we used to be doing 5 or 10 years ago, and doing it through a 1 centimetre incision through the groin. And you can argue that where the various approaches lie along that line as to how invasive they are, how minimal they are, and how effective they are. And I think as things are changing, surgeons around the country are taking on these things. It is very important that we have the evidence to support what we're doing. And the more trials, we've been in the May session earlier this morning, and people were saying we shouldn't be doing trials, the answers are already there. But I think it's vital if we're going to change our practice so profoundly that we should have the evidence on which to base it. Minimally invasive AVR, there is a lot of debate about the incisions done. The very first descriptions were back in the mid-1990s and actually involved taking 2 or 3 intercostal cartilages out, and was first described by Cosgrove. And they used to divide the right internal mammary at the same time. As you've been hearing, the hemisternotomy down to the 4th space is probably the most commonly performed procedure. There's various transverse sternotomies and clamshells have been described. Anterior thoracotomy is growing in popularity. Quite a few surgeons are now doing that. One of the problems with transverse with anterior thoracotomy is it is limited to only a number of patients. It doesn't seem to be applicable to everybody. And then finally, how minimally invasive can you make the operation? Can you limit it just to the sternum and taking it just down to the 2nd space? And that's what I was planning to talk about today. So why are we actually performing minimally invasive surgery? As all of us would know, that the age of the patients is increasing. I think the average age for an aortic valve in the UK has gone up by 10 years over the last 10 or 12 years, looking at the national data set. And as the patients get older, they obviously get sicker and increasingly frail. And as surgeons, we should also always be aiming to improve the quality of what we do, trying to reduce the patient's morbidity. The mortality for an aortic valve replacement is pretty low, but however much you can reduce it, the better, obviously. But there is still a considerable morbidity associated with open sternotomy. And the NHS, as we've been hearing, the NHS is obsessed with resource utilisation. So anything that you can show where the patients cost less, they stay in hospital less, these are all going to be good things. And again, just running through some of the things which you've already heard today. What are the possible advantages of Mini AVR? Well, in theory, there's less tissue trauma. It should hurt less because you're not having to divide all of the sternum, you're just dividing part of it. You've got less area, less bone to get infected. You're less likely, therefore, to have sternal dehiscence. You've got less raw area from the cut areas of bone, so hopefully it should bleed less. and if the sternum is more stable, hopefully they should mobilise, and the respiratory function should be better. You're going to get less post-operative chest infections. And I think people may be sceptical about that, but it's always anecdotal, but I have patients who are going back to playing golf and things after 5 or 6 weeks who've had a mini sternotomy, and that would be pretty unusual for somebody having a full sternotomy. So this is very important. The standard advice after full sternotomy is 3 months off work, but if we can get people back to work quicker, I know our patients are very elderly, but anything that gets the cost of the economy, if they can get back to work more quickly, is a good thing. And the final, I've put it at the bottom of this, is cosmetic considerations. My own view is that we shouldn't be doing cardiac surgery for cosmetic reasons. You don't try and, if somebody brings you take a car to have its engine fixed, the fact that the mechanic can do it without opening the bonnet is pretty irrelevant if the engine doesn't work at the end of the time you had it fixed. I'd much rather the engine worked, obviously. But actually, when you ask the patient, we did a questionnaire survey, and the question, it's a slightly daft question, would you prefer a big incision or a little incision? And you'd be very surprised to learn that 100% out of 60 patients chose the small incision. So, patient choice. So coming on to the debate, why the second space? As we've already heard, hopefully we're going to find out in 6 months' time why the fourth space is a good operation. But actually there's a few randomised trials out there, they're fairly small, and they don't, although there's lots of small benefits, there hasn't been shown to be any big benefit of doing minimal access surgery compared to a full sternotomy. Thoracotomy has lots of theoretical advantages, but when talking about the learning curve, it is a much harder operation to do, doing it through the second or third space. The access isn't as easy as doing it through a conventional incision. Even the experts find they can only do it in about 30 or 40% of the patients. You have to do CT scanning to see how you can do it. It's not applicable to every patient. You can't just put a patient on the table and say, we're going to be doing this procedure on you. So in view of that, we were trying to pick something which would be applicable, we thought, to just about everybody. There is some thought that thoracotomy may be cosmetically better than to doing an upper mini sternotomy, though. So what have we chosen to go with? We chose to try and just limit the sternotomy to the manubrium itself. Our view was that it is a truly minimally invasive procedure. Those of you doing TAVI, the incision is pretty much identical to doing a transaortic incision. And actually, it was doing transaortic TAVI that persuaded me that it was possible to do an AVR through the small incision. I think after doing 4 or 5 transaortic TAVIs about 3 or 4 years ago, I thought, why on earth aren't I actually replacing the valve? I can see the whole aorta, and we're fiddling around putting things in through catheters when I could have just chopped it out and done it the standard way. And so the merging of the TAVI programs and the minimally invasive programs has been very beneficial from that, actually realising what is possible. The feeling was that it was applicable pretty much to 100% of the patients that we see, and we thought because it's much more analogous to a conventional AVR, there would be a much less steep learning curve. Coming back to one of the questions that was presented earlier, we have got some data from Middlesbrough. We came out with a figure of between 25 and 30 cases until the results seemed to plateau off in terms of things like cross-clamp time and operative times while we were learning to do the procedure. So that our view is that you do need, it's not an operation you do once and you're good at. It does take a little bit of time to learn. I'm just going to quickly run through the nitty-gritty of how we do the operation in terms of pre-op, operative and then post-operative care. The pre-op assessment, we started off CTing absolutely everybody. There is some benefit to doing this, not least of which it does tell you how calcified the ascending aorta. You do find there's quite a few patients that are calcified, which you didn't expect before. Not that that stopped us doing the operation necessarily. We've had a few patients where we've had to do root replacements slightly unexpectedly because the echoes and things haven't previously told us, or the cardiologists haven't been kind enough to tell us that the root's slightly bigger than we thought. It's useful in telling you how far it is from the sternum to the aortic valve, and when we were learning how to do it, it's quite important that it's less than the finger's depth, because then you can tie all your knots with your finger rather than having to use instruments to tie the knots. As a rough guide, you don't want anything more than sort of 10, 11 centimetres from the skin edge down to where the valve is. And also, if you're going to go down the route of doing a thoracotomy, the position of the aorta behind the sternum is very important. If you're going to do a thoracotomy, you want everything to be to the right side, whereas doing it through the sternotomy, it's less of an issue. And this just demonstrates that. You're just measuring the distance from the chest wall down to the valve through the second space. That gives you an indication of how easy you're going to find the operation to be. And then the same patient, how far the aorta is to the right side of the sternum. And this would be pretty much behind the sternum, so it would be deemed not to be suitable for a thoracotomy. So how do we actually do the incision? Because I'm not a great fan on the cosmetic side of it, I don't think trying to do it through a 3 centimetre hole and then dividing the bone for miles is a great thing. So you make the skin incision pretty much the same as you do the bone incision, but basically from the bottom of the sternal notch down into the second intercostal space. And then one thing that does help is if you actually, this diagram is not perfect, but you actually make a V-shaped incision and just base it just on the top of the costal cartilage. Unfortunately, the illustrators put it a couple of millimetres above, but actually when you're doing it for technical reasons, you take it right down onto the top of the second cartilage. And the V-shaped incision does help. It gives you an extra centimetre of view, which gives you which obviously is benefit. And when you come to put everything back together again, it's like a key. You've got the V sitting into the V when you're pulling all the wires together. So we do find that the V is helpful rather than just teeing it off horizontally. The cannulation is different from doing it as the Patworth group have described. The arterial cannulation is as normal. I use a slightly different cannula than I do normally, but only because it's slightly more flexible, because you can then bend it away outside the retractor. But it is just a standard ascending cannulation. The venous cannulation does have to be femoral, because you don't get a view of the right atrium in the vast majority of the cases. But it's not a tricky thing to do. It's just a percutaneous selding a wire into the groin with your anaesthetist, giving you a view of what you need to see in the right atrium. And we found this catheter is particularly useful, the Eshtec cannula, which has holes which sit in the IVC and some holes which sit up in the SVC. And we haven't had any problems with venous drainage, and it's been particularly good to use. And again, just demonstrating the view that you need. This shows, I'm a strong believer that the anaesthetist, you should be able to use any anaesthetist to do the procedure. You don't need a special anaesthetic team that you have to get them all organised months in advance to do the operation. You ought to be able to turn up on the day and just do the operation. But the one thing they do need to be able to do for you is get you a decent bicaval view of the right atrium. And this just shows the guide wire going across into the SVC, and then you just confirm that the pipe is sitting in the right place. Otherwise, well, I don't know how many anaesthetists there are in Nuance before I'm too rude. The rest of the operation anaesthetically is very similar to any other AVR. The venting, we have gone around the houses a little bit on how we vent the heart. We started off just dropping the sucker into the aortic root, which is how I would normally do an AVR. Unfortunately, when the view is limited, having a pipe sticking in your way does tend to get in your way when you're trying to operate through it. So then went through doing a pulmonary vein vent. That's quite fiddly when you've gone through the second space to get them in. Although it's perfectly possible, and when you're doing a full root replacement, it's by far the best way, because it gives you perfect view. But for standard valve replacements, just shoving the sucker into the pulmonary artery has become our preferred route. It's not perfect, but it actually gives you, 9 out of 10 cases, it actually gives you a perfectly adequate view of what you need to see. And finally, we have tried, there is a percutaneous device which you can use. Very much the anaesthetist pop it in for you, just like using a swan. We did use it for quite a few cases, but we've moved away from that, just sticking the sucker in the pulmonary artery, which is quick and easy. This might surprise everybody, but actually doing the valve replacement is exactly as you do it normally. So there's nothing really much to say. When we started off doing it, we were just using ordinary instruments. I have actually personally gone over to using the minimally invasive instruments because I think it keeps your fist out of the line of view, but it's perfectly feasible to do them with just as you would any other AVR. The things at the end, you have to de-air the heart. You can't see any of the ventricle to de-air, which we thought would be a big issue, but actually turns out not to be too much of an issue, whether it's because there's plenty of blood just sitting in the heart because you haven't been lifting it up during the case. We've used CO2 on the TOE. You just get the anaesthetist to bag up just as you would normally, and there doesn't usually seem to be very much air in there at the end. One of the differences and one of the reasons why the cross-clamp times are slightly longer is you have to do the drains and the pacing wires before you take the clamp off, because once the clamp comes off, everything disappears out of view. I was brought up that you always put dual pacing wires on every valve replacement. Funnily enough, when you can't get them on, the rules seem to not apply. And miraculously, you don't seem to need them. But actually, as long as you put them on before the clamp comes off, you can nearly always get a ventricular set of wires on. And if you can't, then we just have to put in a percutaneous lead. But I don't think we've actually had to do that yet. We've had them all on the side, and everybody's been panicking if we have had to do it, but it's not been an issue. We don't normally bother with atrial pacing wires. The drains, we've been around the houses, but the easiest place is to actually just put it in subxiphoid before you take the clamp off. And you only need one drain, because the patients never bleed, he says. Closure is very simple. You just a series of wires just to close the manubrium and across the cut. And it's not surprisingly, the post-operative care is exactly as you would for any other AVR. So what are the results of what we've been doing so far? This is actually just the first 18 months. We started in late 2011. We've actually done, I think it's 180 something cases now, but this is just an analysis when we were setting up the trial of the first, well, not quite 100, but the first 98 patients that we did. 2 of us went off to Italy to learn how to do it in Massa and came back inspired, and pretty much since then I think neither of us have done a conventional AVR out of choice since the day we got back. I think with the exception of endocarditis and redos. So otherwise, our view is every AVR is suitable to be done through a mini sternotomy, and that particular case, one of the things we were discussing earlier was that obesity. The obese patients do particularly well with a mini sternotomy. So this is just a comparison in Middlesbrough. Somehow we managed to pinch 98 patients while our 5 colleagues only got 93 during the same time period. But there was a bit of case selection, well, not case selection, but because we were setting up the program, our colleagues allowed us to pinch the AVRs off the list. So we got the thing up and running nice and quickly, which has been great. But apart from being given the generic referral so that we could do that, there hasn't been any particular selection that you do this one, you do that one. But so it is a random, well, not random, but it's quite a good comparison of the practice during that time. But it is comparing 2 of us versus our colleagues. And just looking at the patients, they're pretty well matched. It came out as significant, the difference in aortic stenosis, but we think that's just to how our colleagues have been entering the data on the database. I think the 2 of us, if they're stenotic, tend to put that down, whereas obviously some of them mixed with a bit of regurgitation, they've labelled it as such. But there's very few purely regurgitant valves. There was no difference in the LV function between the groups. The increasing numbers are coming through the TAVI MDT, which is why the numbers of AVRs are going up. There's very little difference in the Euro scores between the 2 groups. The sort of valves put in were very similar. The valve size, the concerns that people might put in a smaller valve, but actually there's no reason why you should put in a smaller valve doing it through a minimal access incision, and that hasn't been borne out. The size of the valves have been pretty much identical. Not surprisingly though, the one thing the things which are different is the operation does take longer. It takes about 30 minutes or so longer to do the whole procedure, or certainly while you're learning to do it. The cross-clamp times and the bypass times are 7 or 8 minutes longer as well. Post-operatively, the 2 groups of patients are very similar. There was a trend to extubating the minimally invasive patients quicker, but it doesn't come out as anywhere near significant. The one thing we have found, though, is that the bleeding has been quite a lot less in the minimally invasive patients. The 12-hour blood loss was 280 mils versus just over 400 mils. And the numbers bleeding more than 500 mils was only 8% in the minimally invasive versus 30% in the conventional group. And one of the other major differences was how they were treated for bleeding. The number of patients needing a blood transfusion was just over 15% in the minimally invasive group, whereas it's nearly 40% in the conventional group. Interestingly, more got reopened in the minimally invasive group. That doesn't come out as significant, but whether that reflects how we were learning to do the procedure, but it doesn't translate into lots of blood transfusion. One of the other outcomes we found, the length of stays are very similar, but actually fitness for discharge or patients being able to go home quickly, we found about 20% of them were able to go home by day 4, which was pretty unusual in our institution when they were having a conventional procedure. There's no difference in the mortality, but you wouldn't expect in a low risk, with a 1-2% mortality risk for AVR, it would be pretty unusual to find a difference. So coming on to the trial, I don't think Sam Nash is in the audience, but it's always good to have a good acronym for a study. Basically, MAVRIC stands for the Manubrium-limited mini sternotomy versus conventional sternotomy for an aortic valve replacement. It's a randomized controlled study. Again, this is a research for patient benefit study sponsored by the NIHR, and it's going to be just done on a single site. Our primary endpoint is the proportion of patients who receive a post-operative blood transfusion within 7 days. And the power calculations have been done based on the preliminary data that you've already seen. Like any other study, we're going to probably measure everything and then see what comes out as well. But there are lots of secondary outcomes. They'll kill me for saying that. But the secondary outpoints are the proportion of patients receiving a blood transfusion, the quality of life, which is obviously very important for the patients. And then the thing that obviously the NHS is very interested in is the cost effectiveness analysis. So who's eligible? Basically, we're going to try and take every patient having a first-time AVR. We're going to exclude the redos. Because blood transfusion is the major outcome, we've had to exclude anybody with a pre-operative haemoglobin of less than 9. And then obviously patients who can't have blood transfusions like Jehovah's Witnesses, we've taken out the infective endocarditis and the hematological conditions. But hopefully that doesn't mean we shouldn't need to take very many out of the recruitment. This wasn't initially part of the study, but the reviewers have insisted that we've made it a blinded trial. Cynically, it'd be quite difficult to the patients not to know whether they've had a big hole or a small hole in their chest, so time will tell how well this actually goes. But it's been something we've been forced to put into the study. So the patients, when they consent, are not going to know which arm of the study they are in. Ideally, we'd like to have randomised in the anaesthetic room, but the anaesthetist and the theatre team told us to get lost at that point. So they are going to get randomised a day or so in advance, which allows a lot of the preliminary stuff to get done and allows the theatre team to set the right equipment up. But when they leave theatre, they're going to have identical dressings. They're all going to have long dressings, both on the chest and on a dressing on the groin. And for the first couple of days, they're just going to be told that they've had an aortic valve replacement. And then on day 2, they have all the various measurements done, including quality of life. And one of the, hopefully, quite interesting questions, see whether we've actually managed to blind them. We're going to ask them whether they know which operation they've had. We could probably make a whole study out of whether the patients can tell from the dressings and the pain, how well the blinding has been. So we'll be wait and see. We might find that every single patient knows which one they've had, or we might find that none of them have had. But my cynical view is that they probably should know which one they've had, but you never know, the dressings might disguise it. Post-operative blood transfusion, the nurses in our unit are very used to following guidelines for transfusion, and I think most of the units in the UK have been doing the tighter trial, so using triggers for when to transfuse and things, and they're not identical to the tighter trial, but it's not dissimilar for those of you who've been closely involved with that. And then we're going to do various measurements just to see how they're getting on. And then the follow-up is 6 weeks and 12 weeks with various questionnaires and looking at resource usage and things like echo outcomes. The trial duration, we've just had the go-ahead, hoping to recruit the first patient in the next week. It's going to go on for around 3 years while we recruit the patients. So it's a 3-year trial, but the recruitment is due to take 30 months of that. And the power calculations are such that we interestingly come out with exactly the same numbers as the Papworth trial with 220 patients, which is slightly quirky, but there we go. And that's just a list of those who are kindly involved with, you might see some names you recognise at the top there. Okay.
Thank you very much, Andrew.
Any questions? Adrian?
Andrew, I'm sorry to sound like a bit of a bastard, but you know, as people know I am. But your first trial that you then work the power calculation on is basically the comparison between 2 different techniques used by 2 different sets of surgeons. Did you ever compare your own results for the 100 AVRs you'd done conventionally with the 100 that you did through a manubrium?
No.
Okay.
I know my bleeding rates were pretty high until I started doing it through the smaller hole. It's in an ideal world, you'd want one surgeon doing all the operations, but we were trying to make it a pragmatic study as the unit.
Because this is a problem with many studies where you've got 2 different groups of surgeons doing two different procedures.
It's a problem. It's a problem if I stood here and told you that one was better than the other based on what I've just told you, because it's not randomised. It's 5 surgeons versus 2 surgeons, and my patients just seem to do slightly better because I took more care on hemostasis at the end of the operation because I was doing a new operation. So it's completely and utterly biased what I've just presented. But once you do a randomised study, that completely goes out of the equation.
I agree with you, but if your endpoint is based upon something that you've actually picked up from something which you say could well be an anecdotal thing, it then becomes slightly more difficult. I agree with you using a shotgun approach because, you know, from finding 15 different variables, you might find one, but, you know, just looking at it as a primary endpoint of bleeding, I think is methodologically a little bit difficult for me to understand.
So I mean, you're absolutely right. The problem is having 2 surgeons versus 5. And in fact, when I first wrote the grant, that's the form that the grant was in. And intuitively, I still think is the best way. Two surgeons who've trained and have expertise in one approach compared to a group of surgeons who have trained and have expertise in another. Like you, the reviewers took exception to this view. And so the way Maverick is actually going to be run is that we've had to train Andrew Owens, another one of our colleagues, to do up to 30 Manubrium-limited AVRs. So there'll be 3 of us doing the operation. During the 30-month period of recruitment, we will do all the AVRs for the unit. So we'll do all the conventional AVRs and do all the mini sternotomy AVRs involved in the trial. And so we remove that issue of sort of one group of surgeons versus another group of surgeons. What we've got is 3 surgeons doing the 2 operations, both expertly trained, and so hopefully some of the concerns that you have will be alleviated.
Okay.
Can I ask a question quickly about your selection of endpoints? Why just bleeding? I mean, my reading of, I don't know how many meta-analyses is, the bleeding is the one thing that always comes out positive. So why not power it to look for something else?
Well, when you're designing a trial, you need to have one thing to measure. That's sort of how you design the trial. So you have to pick one thing. And based on, as Andrew showed, the preliminary analysis, bleeding was clearly the thing that was different. And when you look at, I guess, similar to the reasons why Title was funded by millions of pounds, blood transfusion is quite a huge cost for the NHS. And when you're applying to the NHS for money, one of the key things they want to see is a significant cost benefit for the procedure. So, you know, if we're able to show that there is a significant reduction in blood transfusion, that translates into quite a significant cost implication for the NHS.
If the distance between the manubrium and the aortic root is more than 10 centimeters, usually it could give rise to technical problems. Am I correct?
That was our view to start with,
Yeah.
but actually...
But in the trial, you're not including that
No.
as an exclusion criteria.
No.
Why is that?
Because as we've got better at it, it's become easier to do even when you can still do it when it's 16 centimetres. I think the biggest one has been 164 millimetres or something. It is possible to do, but it's an awful long way down.
Just a quick question for the panel as a whole. Where do you see Mini Access AVR sitting? All the data that we've seen says the cross-clamp time is a bit longer. So for a fit person with a good ventricle, it's fine. But what about, is everyone comfortable choosing minimal access for the little old sparrow-like lady that you've discussed in the TAVI MDT that's got a bit of a dodgy ventricle and is a bit frail? Do you see that they're the people that are more suitable for a longer cross-clamp time, or do you see as doing sutureless valve mini access in that group as the first choice? Interested in the panel.
I don't think the cross-clamp times are that much longer. I mean, 6 or 7 minutes is probably, yes, it's significant, but it's not a big issue. I think we are heading towards sutureless valves. I am a fan of sutureless valves, and we have got permission to use sutureless valves in the trial. So, what proportion? The biggest issue for us is funding for the sutureless valves. We're only allowed to put 20 a year in, so it'll be only a tiny proportion of the cases going through the unit.
Otto, I wonder what you thought about that question, because you've got some experience of stealing TAVI patients and doing conventional operations on them.
Yeah, there is the discussion is going on about disadvantages of TAVI, and patients more and more know it. And as more patients, low-risk patients, are included, the discussion comes up really about the quality of the procedure itself, regarding pacemaker necessity, regarding leaks and so on. So with the usage, more and more usage of the minimal invasive techniques, a lot of patients could be convinced to go back to the gold standard surgery with using the sutureless valve. There is no longer clamp time, there is no compromise to be made. All these sutures to be placed through these small holes, it all falls away. So the operation really is no different to what you would expect with a median sternotomy.
I mean, I think I'd just like to second that, really, because I do this operation using conventional and sutureless prosthesis, and the sutureless really does make a difference.
Yep.
There's one more question there.
One point, I'm very glad you surgeons all over their learning curve, and the same surgeons are doing both operations. But I'm slightly concerned about the endpoint too, because bleeding is only one factor. If you're just measuring bleeding and not measuring return to theatre, then there's potential bias. You showed already in your results beforehand that the minimal access patients were more likely to go back to theatre to be re-explored.
It's one of the secondary measures.
We are
Right. So you are looking at, because you could easily get a very low bleeding rate by taking everyone back to theatre once they bleed more than 50 mils.
No, we're measuring it, but it's not the primary outcome of the study.
Okay. And is there any way to have a primary outcome that's a factor of the amount of bleeding plus integrating return to theatre?
There probably is, but then you probably have to have a much larger N number, because of course your return to theatre will be quite small.
Yeah.
But there probably
You hope.
is.
Yeah.
Yeah. You hope.
It's the pragmatic thing of running a study that we could take 15 years recruiting, and especially if we only manage to recruit 20 or 30%, it would take forever, which is why a lot of studies don't get done. So it's getting some meaningful outcome measure without trying to be, you can't use mortality or stroke because the number. Yeah.
I think you have to start somewhere. You have to end somewhere as well. I've been given the signal that the session's over. My view on the minimally invasive aortic story is that these are all small increments, and no one thing is a complete game changer. I mean, I think we have to remember that the really invasive bit about aortic valve replacement is the bypass. So we've got to think of mini bypass and cardiopulmonary bypass physiology, as well as fancy valves and small incisions. Do you want to?
Yes, so just to end, we'd just like to on behalf of the society, present Professor Dapoons with a small token of our appreciation for the excellent talk that he gave earlier on today. Thank you.